This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
This is Katie Krulisky from the University of Utah in Salt Lake City. Today I'm talking with Stefano Meletti. He is Director of Neurophysiology Unit and Epilepsy Center and Professor of Neurology at Unimore in Modena, Italy. His clinical and research activities comprise epilepsy, sleep disorders, and neuroimaging. We will be discussing his recent paper published in the Neurology journal titled Persistent Postictal Central Apnea and Focal Seizures, Incidence, Features, and Imaging Findings. Welcome, Stefano, and thank you for joining us.
Thank you, Katie. I'm very happy to be here with you.
So let's just get right into the meat of the paper. What do you think is the take-home message of your study, and why is it clinically important?
Our study is of clinical relevance because we studied the features of ictal and postictal respiratory alteration in focal seizure, not only in seizure with a generalized convulsion, but in seizures that are self-limiting without proceeding to a convulsion. And we demonstrated that postictal apnea is present in about 6% of focal seizures. And why this finding is of clinical relevance? We think that our findings highlight the importance of cardiorespiratory recording in long-term VDG monitoring. And this is of relevance because we know that postictal respiratory alteration are relevant to stratify the risk of sudden and unexplained death in epilepsy in person with epilepsy. And we know since many years that after a generalized convulsion, rarely the patient lose breathing activity in the postictal period, and that this could be a fatal event. And in our study, we demonstrated that rarely this postictal apnea, sometimes also quite long, can be present also during focal seizure. This is the main message of our study.
Stefano, that's very interesting because, as you said, in the epilepsy community, we're very familiar with counseling patients on the risk of sudden unexpected death in epilepsy. And typically that risk has been tied into uncontrolled generalized seizures, especially that are happening overnight. So this adds in another segment of dialogue to that discussion. Do you recommend adjusting the way that we counsel seizure patients on SUDEP based on your findings?
I think that when we have recorded and demonstrated that the seizure of a specific patient are associated with ictal and postictal apnea, even in focal seizure, it is important to speak and to inform the patient about these phenomena, because we now know that this kind of small and not dangerous phenomenon during focal seizure can be nevertheless associated to an increased risk of SUDEP. There is, however, an important point is that patients, unfortunately, are not aware of their ictal or postictal apnea. And this was demonstrated in many studies, not only in our study, but also in previous studies from different researchers, that patients are totally unaware of ictal and postictal apnea. So it is important to record with cardiorespiratory monitoring long-term VDG recordings in order to demonstrate and to find out if focal seizure of a specific patient are seizure with ictal and postictal apnea. So I can say that adding even a single respiratory channel using a simple thoracoabdominal belt to a standard VDG, which already include the ECG recording, could provide an insight into SUDEP risk and whenever seizure with periictal respiratory changes are captured.
Is there a specific area of onset that was more associated with the ictal and postictal apneas?
Yes, in our study, but also in previous one, it was quite clear that seizures involving the temporal lobe and the amygdala in particular are the ones that carry a higher risk to have an ictal or postictal respiratory alteration. And this was nicely demonstrated also in study with intracranial EEG, both by the recording of spontaneous seizure, but also by intracerebral electrical stimulation of the hippocampus and of the amygdala that clearly can elicit apnea that is time-dependent to the electrical stimulation. The amygdala and the temporal lobe are the are not the only regions that can cause breathing alteration during seizure, but probably are the regions that are most frequently involved.
And in your opinion, how much do neurologists know about the frequency of respiratory changes during focal or generalized seizures?
In my clinical experience, but also according to a recent survey that we conducted in Italy across Italian epilepsy centers, we noted that only about half of epilepsy centers are aware of the occurrence of ictal and postictal apnea in focal seizure, and no more than 10-15% of centers regularly record cardiorespiratory parameters during long-term VDG recording. This is a kind of neurophysiological monitoring that is a standard of care in sleep center, but is not so a standard of care in epilepsy center in long-term VDG monitoring unit in epilepsy center. And this is a point that it is very important. It is acknowledged that we must increase in the epilepsy community, and that also some international organizations like the International League Against Epilepsy and the International Federation of Clinical Neurophysiology should have a role in this in order to increase the standard of care for patients with epilepsy. This is a very important point because, as I already said, this is something that can stratify the risk to have a dramatic event like SUDEP. So it is important to get insight into the respiratory alteration during seizure.
Definitely. And I know that in the States, we typically have our patients on an SpO2 monitor. But in some situations, depending on the duration of the apnea, this might not be sufficient to pick up that change in breathing directly associated with the seizure discharge. Do you guys use that kind of monitoring in Italy as well?
We use a standard of care cardiorespiratory long-term monitoring, and also we take care to monitor oxygen level during long-term VDG monitoring. And this is important, and we should work in order to increase this kind of cardiorespiratory monitoring that should be a standard of care. In my opinion, this kind of cardiorespiratory monitoring now is more diffused in the US rather than in Europe. This is personal opinion, but I think that in the US is something that is more diffused.
I think we use it quite heavily. I did part of my training in Australia, and now I'm here in the US practicing. And I have to say, we tend to be a very risk-averse community. So anything we can do to reduce our perceived risk, we do. We love our monitors. We love our numbers.
I think that we should promote by ILAE and the International Federation of Clinical Neurophysiology to clearly state that cardiorespiratory monitoring, not only cardio, but also respiratory monitoring, should be a standard of care when we do a VDG recording or a long-term VDG recording. Because now cardiac monitoring is a standard of care. It's clearly stated in many papers that deal with how to do a VDG monitoring. But respiratory monitoring is not so stressed and is not suggested or a relevant parameter to get during VDG monitoring. As I told you, is something that is a standard of care in people who do sleep research. When we do video polysomnography, of course, respiratory monitoring is a standard of care. But in the epilepsy monitoring during daytime, also during brief 1-2 hours VDG recording, respiratory monitoring is not a standard of care. Very few centers, at least in Italy, but I suspect also in Europe, I don't know, in the US, regularly record respiratory activity and also oxygen saturation during a 1, 2, or 3 hours VDG recording. And I think that an important point should be to increase this practice. And I think now it is really important because we now know that even recording focal seizure with ictal and postictal apnea, even apnea is quite prolonged, be associated with an increased risk of sudden unexplained death in epilepsy. So it is something that is very important, and it's something that we can measure, and we can get some useful information to patient, and also we can decide the best strategy to cure the patient.
I totally agree with you. In those epilepsy monitoring units, the main focus is trying to capture the seizures and the onset pattern for surgical exploration and options. And I agree with you in that we need to make it more of a co-emphasis on what are the specific patients' risk factors for SUDEP. And this brings that point to light. And also in your paper, you mentioned some of the structural differences found in patients that are more prone to ictal and postictal apnea. What are those findings?
We observed that amygdala in particular was a subcortical structure that was enlarged, that showed an increase in volume in patients with ictal and postictal apnea. This, of course, was an imaging study at group level, so we cannot say at single subject level if a specific patient has an enlarged amygdala. But we have the data to show that on average, the group of patients with ictal and postictal apnea show an amygdala of increased volume respect to patients with temporal lobe epilepsy without ictal or postictal apnea. And interestingly, the amygdala that show an increase in volume was the one ipsilateral to the epileptogenic zone. And we were not so surprised of that finding because we already know that the amygdala is involved in the circuit that promote ictal and postictal respiratory alteration because, as we have told, we know that amygdala is one of the key structure whose activity is recorded during seizure with ictal and postictal apnea. Probably because we know that amygdala has a direct connection with brainstem respiratory centers, and ictal activity in the amygdala can cause a stop of activity in brainstem respiratory centers. So the finding of an increased volume of the amygdala was somewhat expected, but I think this can be also another step of knowledge that we can add to the field of research that now is aiming to stratify the brain networks that are involved in respiratory alteration during and after seizures.
It is a very interesting point because I'm certainly aware that with amygdala involvement, that can impact respiratory centers, but I have not thought about it in a way that we focus on it structurally. For example, when we're doing our surgical case conferences, I'm not as familiar as looking at the volume of the amygdala. So it's an interesting additional point to bring in to raise our level of suspicion that there might be ictal or postictal apnea.
Yeah, absolutely. Yeah, we have to say that the topic of enlarged amygdala is quite debated in the epilepsy community, and there is now a lot of research on this imaging finding because we don't know if enlarged amygdala is a consequence of ictal activity that involves the mesial temporal lobe structures or is something that is related to the etiology of epilepsy in that specific patient. We don't know what is the exact meaning of enlarged amygdala, but by the way, we clearly demonstrate that there is an association between amygdala enlargement and ictal and postictal respiratory alteration.
And that's part of what is so interesting about epilepsy. We've certainly come so far from where we've started in terms of the treatment options we have available for these patients. And we have still so much more to learn. I just love working with this patient group and learning more every step of the way. And as part of your work, so what interventions were required, if any, to stop the postictal apnea?
We observed that ictal or postictal apnea can occur during daytime, during seizure when the patient is awake, and also when the patient is sleeping. But in seizure during sleep, especially if the patient is untested or unwitnessed, the postictal apnea tend to be longer. This means that a simple intervention by a caregiver, by an EG technician or a doctor to increase the level of arousal of the patient or to awake the patient reverse the apnea. So this means that if the patient is untested and witnessed and is alone, and this is something that frequently occurs at home during night, postictal apnea tend to be more prolonged and could be also more dangerous. But it's very easy to reverse apnea, simply to increase the level of arousal of the patient.
And you mentioned this in the discussion, I believe, in your paper as an area of opportunity for wearable devices within the epilepsy community.
We are in a period when there is an increasing development of wearable technology to alarm a patient or caregiver when seizure occurs. And I think that in the future, wearable devices could also has a role in order to arouse the patient in the postictal period, for example, by means of emission of a loud noise or a vibration during the postictal period, in order to try to awake the patient, in order to improve level of arousal, and this can reverse the apnea, during the postictal period. They think that in the future we can expect to see some devices that have this kind of activity to reduce the risk of prolonged postictal apnea.
It's a very exciting idea because something so simple as emitting a sound could help get someone out of the postictal apnea period. It's so simple and yet has the potential to be so revolutionary.
Totally agree.
Thank you again, Stefano, for taking the time to discuss your work looking at postconvulsive central apnea and focal seizures as a contributor to sudden unexpected death in epilepsy. The paper is titled Persistent Postictal Central Apnea and Focal Seizures, Incidence, Features, and Imaging Findings, and you could read all the details in the Neurology Journal.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.